Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to today's deep dive. If you're tuning in, we are speaking directly to you, the fellow surgeon or doctor looking to refresh or maybe refine your anatomical and surgical knowledge today.
Glad to be here for this one.
Yeah, we know your time is incredibly valuable, whether you're listening on your morning commute, killing time between cases in the surgeon's lounge, or just, trying to keep your clinical edge razor sharp.
Absolutely.
Our mission for this deep dive is to completely master the nuances of the femoral canal and confront the really high-stakes, high-stress reality of femoral hernias.
Which is something every acute care surgeon faces eventually.
Right. We are bypassing the basic textbook diagrams and translating this pathology directly into the operating room. But before we get into the literal meat of the subject, we do need to establish the clinical ground rule.
Right. The mandatory clinical disclaimer. So the following content is strictly for reference and educational purposes only. You must always follow local guidelines, hospital protocols, and your own clinical judgment in your actual clinical practice.
Perfect. Because this deep dive is a tool for understanding, not a substitute for formal directives.
Exactly.
So the hook of today's topic really relies on the deceptive nature of the femoral canal. I mean, we are dealing with a tiny 1 to 2 centimeter potential space.
It's remarkably small.
Yeah, and on a routine scan or during a standard dissection, it usually just sits there holding a bit of extra peritoneal fat and maybe a single lymph node. It looks entirely benign.
Right, until it isn't.
Exactly, because under the right intra-abdominal pressure mechanics, that tiny space transforms into a literal trap, leading to some of the most stressful surgical emergencies you will face on call. Okay, let's unpack this, starting with the basic geography of the region.
The geography is really the foundation of the trap. If you take a look at the compartments of the femoral sheath in the femoral triangle, you navigate from lateral to medial using the classic naval mnemonic.
Naval.
Yeah, naval. Everyone learns nerve, artery, vein, empty space, lymphatics in their first year of training.
Right, but the critical focus for us as clinicians is that empty space, the femoral canal.
And calling it an empty space is honestly a massive anatomical simplification.
Yeah, it's highly dynamic.
Exactly. It's a potential space.
Yeah.
Its physiological purpose actually ties directly into hemodynamics. It exists to allow the femoral vein to expand laterally when a patient's venous return increases.
Like during strenuous exercise or heavy lifting.
Or any prolonged Valsalva maneuver, yeah. And to maintain that compliant space, it contains a plug of fatty extraperitoneal tissue, some lymphatic vessels, and that deep inguinal lymph node.
The node of Cloquet.
Right, the node of Cloquet or Rosenmuller.
Now, keeping the differential diagnosis clean in the heat of a rapid assessment is vital. We should clearly delineate the proximal femoral canal from the adductor, or the subsartorial canal.
Oh, absolutely.
Because the adductor canal is located much further distally down the thigh. It transmits the saphenous nerve and the superficial femoral vessels.
It has absolutely zero structural role in femoral herniation.
Right, zero. The pathology we are focused on today happens right at the proximal thigh, immediately below the inguinal ligament.
What's fascinating here is the absolute unforgiving nature of the proximal opening to this canal, which we know as the femoral ring.
Unforgiving is the perfect word for it.
You can visualize the femoral ring as a rigid, unyielding box. It's this musculo-aponeurotic collar, and the specific composition of its borders dictates exactly why femoral hernias behave with such brutal ischemic efficiency.
So let's break down that box. Forming the anterior roof, you have the inguinal ligament.
Correct.
And then forming the posterior floor, you have the pectineal ligament.
Cooper's ligament.
Right, Cooper's ligament sitting directly over the pectineus muscle and the superior pubic ramus. So you are dealing with solid, unyielding bone covered by dense ligamentous tissue.
Then medially, the border is defined by the lacunar ligament, or Gimbernautz's ligament.
Which is notorious.
Highly notorious in emergency surgery, because it presents this sharp, crescentic, aponeurotic edge.
Almost like a blade.
Very much so. And finally, bounding the lateral aspect is the femoral vein, which is separated from the canal only by a thin fibrous septum within the femoral sheath.
So you're looking at an anatomical choke point. 3 sides composed of rigid, inelastic connective tissue and bone, and one side bounded by a compressible vascular structure.
That structural setup perfectly explains the pathophysiology. Mechanically, A femoral hernia develops when a peritoneal sac is forced through the weak spot at the top of this ring,
Right, traversing that fatty extraperitoneal tissue of the femoral septum.
and the sac is driven down into the canal, emerging anatomically below and posterior to the inguinal ligament.
So how do things go wrong from there?
Well, as that peritoneal sac descends, it draws in adjacent abdominal contents. Now, sometimes it just contains preperitoneal fat, which can look misleadingly benign on ultrasound.
Or an early CT scan.
Exactly. Or it might just be a plug of omentum.
Right,
But the primary surgical concern is the entrapment of small bowel.
right.
The architecture of the femoral ring leads to a disproportionately high frequency of Richter's hernias in this exact location.
And the implications of a Richter's hernia in the femoral canal are terrifying.
Totally.
Because only the anti-mesenteric wall of the bowel gets trapped in the defect, right? The actual lumen of the bowel often remains completely patent.
Which is so deceptive clinically.
It is. You have a patient who might still be actively passing flatus or even having normal bowel movements. It completely masks the classic clinical picture of an obstruction.
While a knuckle of their small bowel is actively undergoing ischemia against that sharp lacunar ligament.
It creates a dangerous false sense of security.
It really does. You might look at a patient with seemingly normal bowel function and delay operative exploration.
Not realizing that full thickness necrosis is happening on that trapped anti-mesenteric border.
And the resulting perforation will spill enteric contents directly into the preperitoneal space or the systemic circulation.
Leading to rapid catastrophic sepsis.
Exact.
Here's where it gets really interesting, though. The unique danger profile of femoral hernias compared to your standard inguinal hernias.
It's night and day.
Right, because we see inguinal hernias all day, and many of them can be managed with watchful waiting. But the risk profile for a femoral hernia flips the surgical timeline completely on its head.
The difference boils down to pure biomechanics. As we discussed, the orifice of the femoral ring is tiny.
Usually less than a centimeter in diameter.
Right. And because it's surrounded by those inelastic boundaries, the sac is tightly constrained the millisecond it passes through.
There is zero compliance in the surrounding tissue.
None. The inguinal ligament does not stretch. Cooper's ligament certainly does not stretch.
And that crescentic edge of the lacunar ligament acts almost like a guillotine blade against the neck of the hernia sac.
So the moment the trapped contents experience even a minor degree of edema, the localized pressure within the sac spikes.
Which immediately collapses the low-pressure venous drainage of the trapped bowel.
Right. And that lack of venous outflow causes massive fluid extravasation and exponential swelling.
Which then rapidly exceeds arterial perfusion pressure.
Exactly. Arterial inflow is choked off, and you enter an irreversible ischemic cascade. This extreme predisposition to early incarceration and strangulation gives femoral hernias an aggressively high rate of bowel obstruction and necrosis.
A patient with a newly symptomatic femoral hernia is a ticking clock.
Without a doubt.
So translating this to the physical exam, the textbook clinical presentation is a swelling or a palpable lump appearing below and lateral to the pubic tubercle.
Emerging under the inguinal ligament.
Right, and positioned medial to the femoral artery pulsation.
While that textbook swelling is helpful when present, the clinical reality is often much more opaque, particularly with the occult hernia.
The occult hernias are the ones that keep you up at night.
They do. In patients with a higher BMI, this small 1 to 2 centimeter lump is entirely obscured beneath thick layers of subcutaneous adipose tissue.
So there's no visible bulge at all.
No visible bulge and often no palpable mass unless you apply very deep targeted pressure in the exact anatomical triangle.
Which brings us to that classic 3 a.m. ward consult or ED call. The patient doesn't present complaining of a groin mass.
They present acutely unwell with an unexplained small bowel obstruction.
Nausea, bilious vomiting, progressive abdominal distension, severe colicky pain.
If you are evaluating a patient, especially an elderly female patient, or someone with a high BMI presenting with an unexplained bowel obstruction, and you fail to aggressively and deliberately palpate the femoral triangle, you will miss the strangulated femoral hernia.
And often the definitive diagnosis is only made once the patient is already undergoing an exploratory laparotomy for presumed adhesive disease.
Right. The surgeon gets in there and discovers a loop of bowel diving down into the pelvis, tethered into the femoral ring.
So what does this all mean? It means your surgical management strategy must be proactive and decisive. The golden rule for femoral hernias, dictated entirely by that massive strangulation risk, is that all identified femoral hernias merit operative repair.
Every single one.
Even in the rare scenario where you evaluate a patient in the clinic who is minimally symptomatic with an easily reducible hernia, watchful waiting is completely off the table.
They're generally listed for elective surgical repair within a tight window, typically about 2 weeks.
Because leaving a known femoral hernia untreated is an unacceptable clinical risk.
The probability of strangulation occurring before their next routine follow-up appointment is simply too high.
So when we are formulating the operative plan, the surgical goals remain consistent regardless of the specific approach, right?
Yes. Safely reduce the sac and its contents, obliterate or narrow the rigid femoral ring to prevent recurrence, and meticulously protect the femoral vein situated immediately lateral to the dissection plane.
Narrowing the ring classically involves suturing the inguinal ligament down to Cooper's ligament.
Or in modern contexts, utilizing a specific mesh plug or a flat mesh reinforcement.
Let's walk through the reality of the classic open incisions, because as a surgeon, your choice of incision is heavily dictated by your preoperative suspicion of bowel compromise. Let's start with the Lockwood approach, the low infrainguinal incision.
The Lockwood approach utilizes a transverse incision placed below and parallel to the inguinal ligament. It provides direct, highly localized access to the hernia sac within the thigh.
So it's an excellent choice for straightforward elective cases.
Right, cases where clinical imaging and exam make you highly confident that the bowel is healthy, easily reducible, or that the sac only contains preperitoneal fat.
You dissect out the sac, reduce the contents, ligate the sac high at the neck, and close the femoral ring.
By approximating the inguinal ligament to the pectineal fascia.
The Lockwood is elegant for simple cases, but it becomes an absolute nightmare if your preoperative assessment was wrong.
Oh, it's terrible.
Imagine opening that sac from below the inguinal ligament and finding black, necrotic, foul-smelling small bowel.
You are structurally trapped. From an infrainguinal incision, you cannot safely apply traction to pull more viable bowel down into the thigh to perform a safe resection.
And you absolutely cannot safely release the ischemic bowel back into the peritoneal cavity without securing it.
Because your exposure of the intraperitoneal space is essentially zero. You are forced to abandon the primary incision, perform a separate laparotomy to manage the bowel, and then return to the groin.
Which is a disaster. Moving up, we have the transinguinal route, the Lothieson approach.
The Lothieson approach utilizes a standard oblique inguinal incision. You open the aponeurosis of the external oblique, open the inguinal canal, retract the cord structures, and then incise the posterior wall of the inguinal canal, the transversalis fascia.
So this provides a route down into the femoral canal from above the inguinal ligament?
Exactly. It gives you far superior control of the neck of the hernia sac from the abdominal side compared to the Lockwood.
But when dealing with a known or highly suspected emergency strangulation, the real hero of the open approaches is the McEvity.
The McEvity is a high preperitoneal approach. You utilize a high vertical or transverse lower quadrant incision, or even a lower midline laparotomy incision.
Right. And the defining characteristic is that you completely bypass the inguinal canal, entering the preperitoneal space high above the inguinal ligament.
This gives you the ultimate high ground. You are looking directly down at the neck of the hernia from the inside of the abdomen.
You have unparalleled visualization of the sac entering the femoral ring.
Right. And if the bowel is tightly incarcerated, you have the direct exposure needed to safely incise the lacunar ligament medially to widen the ring.
Though, during that maneuver, you have to maintain intense vigilance for the corona mortis.
Yes, that aberrant anastomotic branch between the obturator and external iliac systems. Injuring the corona mortis here can cause catastrophic pelvic hemorrhage.
But once you safely widen the ring, you apply gentle traction to pull the bowel back into the peritoneal cavity.
And if you inspect the tissue and confirm it is irreversibly ischemic, the McEvity approach has already provided you with the excellent peritoneal exposure required to perform a standard bowel resection right there in the field.
Primary anastomosis and everything.
Exactly. After the bowel is managed, you clean the field and repair the hernia defect from that same superior vantage point.
It is a highly versatile approach that perfectly illustrates how the suspicion of ischemic bowel must dictate the entire surgical exposure strategy.
But, the landscape of hernia surgery is continually shifting toward minimally invasive techniques.
Right. If we connect this to the bigger picture, we really have to deeply examine the modern options. laparoscopic TAPP, transabdominal, preperitoneal, and TEP, totally extraperitoneal repairs, alongside robotic-assisted techniques.
These approaches have fundamentally revolutionized our structural view of groin anatomy. Minimally invasive techniques essentially allow you to view the defect from the inside out.
Similar to the preperitoneal view of the McEvity?
Yes, but enhanced with high-definition magnification, superior illumination, and pneumoperitoneum acting as a blunt retractor.
It's a game changer. The dissection planes allow you to clearly identify the key landmarks: Cooper's ligament, the inferior epigastric vessels, the iliopubic tract.
And these approaches are incredibly powerful because they allow the surgeon to deploy a wide sheet of prosthetic mesh, often 15 by 15 centimeters.
Covering the entire myopectoneal orifice of Frouchot, you aren't merely plugging a single femoral defect anymore.
No, you are simultaneously reinforcing the direct inguinal space, the indirect inguinal space, and the femoral canal with a single piece of mesh.
Which is huge because epidemiological data shows us that groin hernias are frequently synchronous.
Very common. An elderly patient might present with a symptomatic femoral hernia, but during a TEP or TEP approach, sweeping the peritoneum back reveals an asymptomatic, concomitant direct inguinal defect.
One that would have been entirely missed during a localized open Lockwood approach.
Exactly. And managing recurrent hernias where the anterior tissue planes are completely scarred down from prior open repairs makes the posterior laparoscopic approach invaluable.
You get to enter pristine, unscarred preperitoneal planes.
It also provides excellent utility for bilateral cases, allowing bilateral repair through the same 3 small port sites.
Now, the critical technical consideration during these minimally invasive repairs is meticulous mesh fixation or modern non-fixation techniques.
Right. If a surgeon chooses to tack the mesh, they must be intimately aware of the triangle of doom.
Housing the external iliac vessels.
And the triangle of pain, housing the lateral femoral cutaneous and genitofemoral nerves. Tacking into the rigid pectineal ligament is safe, but straying laterally into those neural or vascular spaces can leave a patient with devastating chronic neuropathic pain or immediate vascular injury.
So synthesizing this clinical breakdown for you as you prep for your next high acuity shift or your surgical board exams, the femoral canal is anatomically small but clinically volatile.
Extremely volatile.
You must retain a clear mental image of those rigid borders, the inguinal ligament anteriorly, Cooper's ligament posteriorly, the sharp lacunar ligament medially, and the femoral vein laterally.
It is that inelastic, rigid box that drives the extreme risk of rapid incarceration and strangulation.
Because of that relentless physiology, you must treat every femoral hernia as an impending emergency necessitating urgent operative repair.
And tailor your approach to the clinical reality. Utilize a simple infrainguinal Lockwood for a confident, planned elective case, but deploy the high-exposure preperitoneal McEvity the moment you suspect compromised bowel.
You need that intraperitoneal freedom to resect and anastomose.
This raises an important question concerning the future of hernia surgery materials.
Oh, definitely.
When we utilize modern, minimally invasive preperitoneal approaches, we frequently staple, tack, or glue a relatively inflexible synthetic mesh directly against the dense, unyielding bone and connective tissue of the pectineal ligament.
Right.
How does that localized, rigid construct respond to decades dynamic pelvic floor movement, continuous intra-abdominal pressure fluctuations, and tissue remodel?
It's a massive unknown.
Are we unknowingly trading a highly successful immediate hernia repair for long-term biomechanical shear stress and chronic inflammatory pain syndromes at the mesh ligament interface in our younger patient populations?
That biomechanical tension between synthetic mesh and the dynamic human pelvis is a phenomenal concept to ponder, especially as we see younger patients undergoing these comprehensive preperitoneal repairs. It forces us to look beyond the immediate postoperative outcomes and consider the multi-decade lifespan of our surgical constructs. And that wraps up our analysis of the femoral canal and hernia management. If you like this content, please don't forget to share it with at least one of your colleagues or friends to spread the word. And make sure to check out our YouTube and other social media pages for more clinical breakdowns. Thank you for listening, and we will see you on the next deep dive.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.